County, so that's exciting. So on behalf of the entire team, I'm Allison Ellzey. I'm a developmental behavioral pediatrician at the University of Utah, and today we're going to be talking about surveillance and screening, which on the surface may not sound like the most exciting topic, but I'm hopeful that by the end of today, we really all learn together how powerful these tools can be in identifying children who have an increased likelihood for autism and ultimately linking them to services. So we do not have any commercial financial relationships to report. However, our work is funded through support from the Intermountain Foundation at Primary Children's Hospital under the ASPIRE project. ASPIRE stands for Autism Services, Personalized, Integrated, Research-Informed, and Empowering. And through this project, we conduct a variety of clinical care and education initiatives and research throughout the state of Utah. And this is just as a reminder, this is part of a series. Last month, we did early signs of autism. So if you missed that, the recording is up, I think, up on the website. And the link to the website, the webpage is on the slides. And then, over this year, we're going to be addressing several topics throughout the year. What's important for you guys to know is that we're still fine-tuning the plan for this year. So if there's any topics that are just really on your mind, please let us know. We're going to put a survey in the chat that will link out to a separate survey that's really just asking for things that you want to know. Because for those of you who are working in the community or your stakeholders or otherwise involved in the autism community, what you want to know is what we want to share with you. So please, so we would love that input. Also, if you do have any cases that you're interested in incorporating into this series, then you can submit those as the way that Michelle and Mindy had mentioned. So today, our plan is to understand the importance of surveillance and screening for autism, define the difference between surveillance and screening, describe and compare commonly used autism screening tools, and describe the limitations of screening for autism in older children, particularly in the primary care population. And then also as a part of this entire series, we have what we call like an equity mini curriculum. It's really important to, I think to all of you who are here and to certainly us on the team that we really understand issues of equity and inequity as it relates to identification of children and care of children on the autism spectrum. So Dr. Villalobos, one of our team members and colleagues, will be presenting today's portion of that mini curriculum, which we'll be doing each month. So just to get us started, I imagine that many of you are aware that autism spectrum disorder is a common neurodevelopmental disability that's behaviorally defined according to criteria specified in the DSM-5, or for those of you who aren't familiar, the Diagnostic and Statistical Manual, which is the manual that clinicians use to apply these diagnoses. And the core characteristics fall under domains of social communication and restricted interest in repetitive behaviors. And so these diagnostic criteria, if you're really wanting to take a deeper dive into those, that's next month. So stay tuned. We're going to talk in detail about all of those next month. But I wanted to give a little bit of an overview as we, to kind of put us all in the same general universe as we're talking about surveillance and screening. So while autism is generally considered to be lifelong, studies have shown that early and intensive autism-specific interventions can improve developmental outcomes. And we'll be talking about that a lot. And that's kind of the reason why early identification can be so beneficial, because we can improve outcomes for children by introducing services earlier. One quick thing, I will say as I'm presenting, I don't have a lot of access to the chat, so please put any questions in there, and then either one of my colleagues will answer that in the chat, or we can talk about it at the end, because I don't see them when they pop up, but please still put in your questions. So before we talk about surveillance and screening specifically as it applies to autism, I wanted to get us all on the same page as far as what do these words mean? Like, what's the difference between surveillance and screening and evaluation? So surveillance is the process of recognizing children who are at risk for developmental delays. And according to the American Academy of Pediatrics, it has the characteristics of being flexible, longitudinal, continuous, and cumulative. So it's all the things that you're doing in the visit on a more informal way to look at development. So it's watching the child play, it's asking the parents questions and talking to them about milestones. These are all examples of surveillance, and we'll talk about that in more detail in a minute. And this is recommended that you do surveillance at all well child visits. Screening, on the other hand, is more formal. It's the administration of a brief standardized tool to aid in the identification of risk. And so the American Academy of Pediatrics recommends general developmental screening at 9, 18, and 30 months, and autism-specific screening at 18 and 24 months. And then evaluation is where you are actually evaluating, looking at a child to identify if they meet criteria for a specific diagnosis, or identifying what specific diagnosis might be applicable to a child. So while screening is not diagnosis, it identifies children who may be at risk. Evaluation is actually applying those criteria and making those diagnoses. So this diagram shows the system that we have in the United States for early identification of autism. So the American Academy of Pediatrics, as we talked about, recommends developmental surveillance for all children at all visits. And when it comes to autism, what we're doing there is talking with parents to elicit concerns, taking a developmental history, observing the child as they're playing and interacting with their parents and with you, identifying risk, strengths, and protective factors. We're documenting that process so that we can look at that over time, and then communicating those findings to others. And then additionally, as I mentioned in the previous slide, it's recommended to administer standardized autism-specific screeners at 18 and 24 months of age. And then children who are identified as having a higher likelihood of autism from surveillance or screening should be referred for an autism evaluation. And again, as I mentioned earlier, if we do all these activities well, what we hope is that it results in early identification of autism, which leads to earlier interventions, which can improve developmental outcomes. So as I introduced in the last slide, during health supervision visits, we should be performing developmental surveillance specifically for autism. This involves asking about developmental or behavioral concerns and really responding actively to those concerns. And I'll talk about that a little bit more in a few slides, rather than passively, like really taking action when parents bring up concerns about development. We should also include autism when taking a family history. And we should make observations that are informed by what we know are early signs of autism. So we've been working with pediatricians throughout the state on some specific things to do in surveillance. And so, two of those things I'll talk about a little bit today. One of them is orienting to name. And so it's very easy to do. You can either have the parent call the child's name, or when you walk in the room, if they're facing away from you, you call the child's name to see if they respond. And I'm going to see if this works. This is just an example of how you might do that and how you can really do that in about, 3 seconds. Let's see.
Hi.
And he also does a nice point, but it's just the idea that when you're even in the midst of your day, as you're going about your regular process, that you can do these quick things that can give you valuable information. The other thing that you can do is assess for joint attention or shared attention by having the child follow a point. So you can either point to something across the room and or have the parent point to something across the room and say, "Hey, Johnny, look," and see if they follow your point. And so those are two things that can inform all the other things you're doing and can give you some windows into social communication. And then the other things that I have on this slide are let me pull up one other thing. Let's see. Oh, my slide is not quite working, but there's two other there we go, resources that I wanted you to be aware of that can be really helpful. So one is the CDC Act Early, Learn the Signs Act Early initiative, and those can give you some really nice examples of different milestones that kids should meet. And the more recent revision from last year actually adds some social communication, some social skills milestones. And then Autism Navigator gives some other really nice examples of developmental surveillance and also just early signs for autism. And so they're really good resources that are free for parents and for clinicians to navigate, to use. So next we're going to move into screening. So as we talked about, screening is that using that standardized tool to assess risk. And so before we jump into autism screening specifically, I just want to review the reasons why why healthcare providers, for those of us who are healthcare providers, would screen for a condition. So we would screen if a condition has significant consequences, if the test has high accuracy for detecting the condition with relatively few false positives, that the screening test itself causes little or no morbidity, that the test is affordable and available, that treatment for the condition exists, and that treatment's more effective when applied early on in the condition or even before symptoms begin, as we know for some of our the medical things that we screen for, and that treatment is not too risky or toxic for the patient, for the person, individual. So why is autism screening important? And I feel like I am sort of saying some of the same things over and over, but it just to highlight how important it is. That screening, surveillance is important and we should do it. But we know that screening can identify children who are missed by surveillance alone. That surveillance alone misses kids. We know that children who screen positive are diagnosed earlier than those who are not screened. It can help address racial and ethnic inequities, as we'll talk about in a little bit later in the presentation. And again, as we've said now, I think 3 or 4 times, early treatment or interventions can improve outcomes. As some of you may be aware, the United States Preventative Task Force did put out a statement in 2016 that did not recommend universal screening based on their opinion that there was insufficient evidence to justify it. However, the American Academy of Pediatrics continues to recommend routine screening 18 and 24 months. And the reasons for that are the ones that we've discussed. The big one, that early intervention can improve outcomes, that signs can be identified reliably in early childhood, as early as 18 months of age. And that there's a high diagnostic stability in children who are diagnosed between 18 and 36 months. And what I mean by that is that when a child has an autism diagnosis, receives an autism diagnosis in toddlerhood, the vast majority of those children persist in having that diagnosis later on. And so the American Academy of Pediatrics does not recommend a specific autism screener, but we're going to talk about 2 different autism screeners today as examples of some of the more commonly used screeners and screeners that you can use. Before we dig into those and talk about them, I do want to talk a minute about language, just so that I don't confuse anyone. And if I do, just please let me know. So the people in the autism community have been, appropriately critical of using language like pass or fail to talk about autism screening. As you can imagine, like failing an autism screener like that, that is somewhat pejorative language. And so I'm instead going to use positive and negative screening to discuss results of screening. And we'll say, instead of high or low risk, we'll try to say high or low likelihood, because that's the preferred language in the community. I will say that, that older terminology absolutely is in some of the literature and in some of the graphics, so it's still in here somewhere, but I'm going to try to stick with that. So the first screener that we'll talk about is one that many of you are likely familiar with, called the MCHAT. That stands for the Modified Checklist for Autism in Toddlers, Revised with Follow-Up. It is the most widely used autism screener. It's free, which is great. It's for ages 16 to 30 months, and it's available in many, many languages. If you go to the webpage, there's most languages you would encounter, although certainly not all are available on the MCHAT. It has not been validated in all of those languages, though, and they may have done a few more since the last time I looked at this, but it's validated in English and in Spanish in Spain, but many of the other languages that have not been validated in that language, although it has been translated. And so the MCHAT is a 2-stage screen, and this is what I think many clinicians may not actually know, that the first stage is the questionnaire. It's 20 yes or no questions. And then after that is a follow-up interview administered by the clinician. And so we know that the follow-up interview is often not performed in real world settings. So in many times when you do the MCHAT, the follow-up interview is not administered. And so the real world sort of sensitivity and specificity, as you can see, there's a studies that have been done fairly recently in the past few years at CHOP, and then one here in Utah that show lower than we would hope sensitivity and specificity, or sensitivity and positive predictive value of the MCHAT. That said, despite that, we do know that we pick kids up on screening that would have been missed if we hadn't screened. And there was a meta-analysis that came out actually last month, so hot off the press, that looked at a bunch of different studies and did show somewhat better sensitivity and specificity depending on the age of the child and other factors, but did overall in the meta-analysis find somewhat better numbers than this. And so when you're looking at the MCHAT, again, on the left side of the screen, this is the total score on that questionnaire. So it's a yes/no questionnaire. And if the total score is less than 3, then you don't need to do anything else other than ongoing monitoring, developmental monitoring, unless surveillance or something else suggests likelihood of autism, and then you would refer. If the score is greater than or equal to 8, then you just refer them for diagnostic evaluation and early intervention, and also audiology evaluation, assume if they have a speech or language delay. And then this middle score, you're supposed to administer an MChat follow-up interview. And that is in the MChat. If you go to the website, mchatscreen.com at the bottom of the screen, that is, free and published. It's questions that you go through with the family to clarify some of those questions that were on the questionnaire. And again, in the real world, which I think many of you can attest, most people actually aren't doing the follow-up interview. And it's just important to know that does affect the performance of the screener. See, here we go. So another screener is called the POSI, or the Parents' Observation of Social Interactions. And it is embedded in a developmental screener called the SWIC, or the Survey of Wellbeing of Young Children. It's a developmental screener that was developed at Tufts. And it is 7 items, so it's shorter than the MChat, and it's really quick to administer and score. So for that reason, a lot of busy primary care practices have really liked using this screener. And I will show it to you in just a minute. But it has 5 possible responses for each item rather than a dichotomous yes or no. It's at the 5th grade reading level. There's English and Spanish versions. And then the items are modeled on the critical questions of the MChat. So before the MChat the first MChat, they had critical questions, and those questions, those POSI is based on those. It is in patients or children 16 to 35 months. And it's important to know that although new studies are coming out all the time, the POSI has been studied less extensively in the general population than the MChat. It has been studied more in clinical and referral populations. And so what is the POSI? Because for those of you who are not familiar, so this is what it looks like. It asks parents to rate the frequency of behaviors. And so a response indicates a higher likelihood for autism if the child does it infrequently or never. And so, for example, this first question asks, does your child bring things to you to show them to you? And many times a day or a few times a day would be the what we would call passing or more negative response. And then these 3 on the right side would be the positive or more at-risk responses. And so we did move to using the POSI at the University of Utah in the hopes that using the POSI would increase our sensitivity by helping to identify children with autism who had more inconsistent social behaviors rather than yes or no. And so we are now using the POSI in our clinics, and we'll talk about how that's gone in just a minute. So this is just for you to see that and we'll talk about scoring it, that you're really, when you score it, you kind of draw a box around these last 3 rows. And then these are the ones that you count as sort of positive or at-risk responses. And so just to give you an example, because that might be a little bit confusing, here is an example of a positive POSI. And so remember, all the things on the left 2 columns are zeros, and then anything in the right column, the right 3 columns is scored as a 1. But it's important to know that you only score 1 point per question. So this gets a little tricky down in these last 2 items because caregivers can indicate multiple responses, but you only give 1 point per line. So this score has this POSI has a score of 3. And so, I think one of the things that clinicians have pointed out frequently who use it, and I don't know if those of you who use the POSI agree with this, is that many children score for this last item that they like to climb, run, and being active. And I think, people are looking at item analysis of these items, but it seems to play out that is true, that for this particular item, many children do respond in this score on that item. So this is just there have been a couple of studies that have compared the POSI's accuracy in predicting a later diagnosis compared with the MChat. And so there's a study of the POSI that was published in the Journal of Developmental and Behavioral Pediatrics that shows that at 16 to 30 months, the POSI is more sensitive and the MChat is more specific. So what that means is that, the POSI, which prioritizes sensitivity, will result in fewer missed cases, so false negatives, whereas the MChat, which prioritizes specificity, may result in fewer false positive cases. And so, it's important to know that this study, as we talked about for some of the other POSI studies, was performed in a referral population. And so that was patients who were referred for additional care, and that sort of population is enriched with children who have developmental concerns, and so may not be, as reflective of the general population, but I think is still good to know. Right. Let's see. Excuse my small technical difficulty. Okay, just boxes. Okay.
And Dr. Ellzey, there is a question. I don't know.
Oh,
if
yes.
I have to wait.
Yes.
So the question is there a helpful suggestion for parents to differentiate many versus few on the POSI?
So really good question. And as far as like officially, I don't think so. There is we'll go back and look at it, but we'll pull this out. So the one thing is that many times a day and a few times a day are both in the sort of quote unquote passing section. And so it's, I think the distinguishing marker is if it's something that they do daily or less than daily. And so that might be where we help families to distinguish that. So if a family were to ask me, and our team can weigh in too, I would say, I would put many if they're just doing it all the time. And then I would put a few times a day if you notice they're doing it every day, but maybe not all the time frequently. But there's nothing in the manual that sort of, as far as I know, that would guide you in exactly how to respond to that question. So good question. So this, as we were talking about, thinking about the POSI being more sensitive and the MCHAT being more specific, that is relevant in this study that some of our colleagues did here in Utah, and that was published in 2021, that looked at in primary care the differences in the screen positive rate between the MCHAT and the POSI. And as you notice, the POSI has a higher screen positive rate of almost 15%, and so as a primary care clinician, for those of you who are in the audience, you might think, well, goodness, like I cannot refer 15% of my patients for autism evaluation. Like there's already a huge waiting list, and you are right. So we talked with the makers of the POSI about how we handle that that reality of the POSI, and they have really suggested that the results of the screen spark further discussion to decide whether or not to refer. And I think using some of the surveillance that you're doing, maybe some of those more structured surveillance items, such as response to name, following a point, parent eliciting any parent concerns related to autism, those can really inform your decision whether or not to refer. But I recognize it's tricky, because part of the reason to do a screen is to remove some of that decision-making burden. And so that's just some of the reality of the limitations of the screeners. One of the questions we get a lot at the university is, well, what about older kids? Like we have older children who may be past their early autism screeners, or were low risk, or had a negative early autism screen, but they're having concerns like when they're in kindergarten or middle school. And what do we do with this? Like how do we screen older kids? And the reality is that there's no validated population-based tools that are recommended for use in general pediatric practice for older kids. There are screeners that exist. The social communication questionnaire is one of them. There are others that are really recommended for use in clinical populations. So what I mean by that is like if someone were to come to a developmental pediatrics clinic for assessment, or a psychologist for assessment, that screener might be used to inform that evaluation, but it's not specific enough for universal screening, like to give in a pediatrics office or a family medicine office. And so what do we do right now? It's ongoing surveillance. And I think being clued into some of these ways that autism can present in older kids can help you enhance that surveillance in your own practice. So why do children present later sometimes? There's a lot of reasons. One of them is appropriately that their symptoms are more subtle, that the sort of differences between their social skills and other children's social skills aren't as obvious until those social demands increase over time as they're older. And so nothing was missed. It just wasn't obvious, or wasn't like clinically obvious until later on. Children with average or above average intelligence, not always. Some of those children do get diagnosed early on, but some of those children can use their cognitive skills to compensate for some of the social and behavioral differences. Differences in early childhood socialization can play a role. And then, we see this a lot in our clinic, that diagnoses of other neurodevelopmental or psychiatric conditions, while often appropriate, can complicate things. So, for example, if a child has ADHD or anxiety and that's already on the books, it's already in the chart, then there's a tendency to attribute other symptoms or other sort of behaviors to that diagnosis. And so a child might have ADHD and have a lot of sensory issues and have trouble making friends, which you can see, that's not part of the diagnostic criteria, but you can see that. But that child might also be on the autism spectrum, but those behaviors can get attributed to the diagnosis they already have. So we see that a lot. And there also is bias that plays a role. Unfortunately, racial, ethnic, gender bias all can play a role in delaying diagnosis, and we'll address that in a little bit and talk about that. And then lack of access, so to information, to diagnostic evaluation. For example, like we know, even like in Utah, our families from children who live in rural areas are identified and are diagnosed later for a lot of access and other related reasons. So when you're sort of, so understanding, it's like, okay, well, we're limited in formal screening. That's a limitation in this age. What can you look for? What would sort of come on your radar as far as thinking, maybe I should think more about autism for a school-age child? So while no one of these things is, of course, a diagnostic, if you have several of these things that come up, it might prompt some further assessment. So trouble making or keeping friends, a tendency to control play, to need things to be on their terms, someone who's described as socially awkward, someone who has difficulty understanding jokes or sarcasm or things that are like not literal. A person who might have a child who might have monologues instead of back and forth conversations. They may talk on and on about a topic and not let other people get in. A child who has pedantic speech, or maybe described as a little professor, or maybe described as speaking as though they're much older than they are. And then difficulty with eye contact is noticed, and it may be more subtle. So I've had teenagers who I've worked with and talked to who describe that they have learned how to sort of hack eye contact by looking between there's someone's forehead between their eyes, and it sort of simulates eye contact. But if you ask them, they say that it's really uncomfortable for them, and they've had to sort of figure out how to do a behavior that is socially, quote unquote, socially acceptable, but that's uncomfortable for them to do. And then some behaviors you might look for are monotone or robotic speech, intense interest, even if they're age appropriate. So this is often described in later diagnosed girls, although it can absolutely be seen in children and adults of any gender, but that an interest might not be atypical. It might be, for example, a middle school girl might be interested in the same boy band as her friends, but may know an excessive amount of detail about them, may talk about them constantly to the exclusion of other topics to a degree that's just beyond what her peers are doing. Distress when routines are changed may also be seen, preoccupation with rules and distress when other people are violating those rules. And then sensory related behaviors can be seen the same as in younger children. You can see that sort of, we talked about that last month. You can see some of the same things such as sensitivity to noises. You can see the same things such as staring at lights or fascinated with movement, but sometimes they can be more subtle. Hair twirling, body focused repetitive behaviors like skin picking, a strong preference for certain clothing fits or fabrics. Like I have, school-age children who I've seen who presented later, like are only wearing the sport fabric, like the athletic sort of smooth fabric, and won't wear jeans. Like but it could be different for anyone, but it could be a little bit more subtle than what we see in younger kids. And so, we know that by successfully implementing equitable autism screening and referral, we have the opportunity to improve care for our patients by facilitating earlier diagnosis and thus referral to services. And this is a study that was from a few years ago, 2016, and it really showed that, parents' first discussion of concerns related to autism with a healthcare provider was at age 2. And that the diagnosis in this group was at 4.5. But when the provider had a proactive response to the concern, they actively referred in response to that parent concern, those children, that resulted in a decrease in age of diagnosis by 1 to 2 years and decreased the odds of a greater than 3-year delay in diagnosis by 50%. And so, the hope is that this proactive response to developmental surveillance and equitable autism screening and referral can really make this gap smaller, can narrow this gap. And so that's, really what we're hoping to do over time by improving these practices. And so now, as I mentioned, we're gonna move to our equity moment, our curriculum within this Autism 101 series. And I'm gonna hand it over to Dr. Michele Villalobos, who again is one of the psychologists and associate professor at the University of Utah and is a researcher in autism, particularly as it relates to equity and inequity. So Dr. Villalobos, take it away.
Hi, everyone. I know there's a couple of questions in the chat.
Okay.
So just so you know, we see them there. And I think maybe after we go through some of these slides, we'll have a few minutes to talk through some of your questions. They look really good. So as Dr. Ellzey mentioned, we're always going to have a few slides built in throughout our Autism 101 series to talk a little bit about how some of the research that Dr. Ellzey's already presented may or may not apply to subgroups within autism. And those subgroups could be by race, ethnicity, gender, or even disability. So we have sort of these generic models for how to support individuals with autism within our system in terms of screening, surveillance, diagnosis, treatment, ongoing care. And as we've sort of built these out, we haven't done a great job of really making sure they work for everyone. So we're going to talk a little bit about the ways in which they work and some of the ways in which they may not be working. So we're going to go to the next slide, and I'm going to just show you a few numbers to give us a good sense of kind of where some of the broader inequities are within screening and surveillance, our ability to identify all children with autism in a timely fashion. That's really our goal, right? And trying to capture who we're missing can be a little bit tricky. So many of you probably see the prevalence data coming out every couple of years that tells us, how many children across the US are being diagnosed and by what age with autism. Generally, what we see is that Black and Hispanic children are diagnosed much later, and they're diagnosed more frequently with intellectual disabilities. That's likely as a result of being diagnosed later. We know that because of the wonderful things early intervention does. I know there's some early intervention folks on here, so thank you. Children develop language a lot sooner, the sooner they're in treatment, and having the ability to talk and to communicate greatly decreases the likelihood of an intellectual disability, especially being able to do so by kindergarten, right? We know that around 2.1% of children in Utah are diagnosed with an autism spectrum disorder. The national rate, which is based on a sampling, not in every state altogether, because we don't have that data, but based on what we kind of have as an average of the US, is about 2.9%. So we have a lot of children that we may be missing here in Utah. We also know, as Dr. Ellzey mentioned, that children in rural areas are diagnosed less frequently. So as of a few years ago, the rates of autism in what are kind of HRSA designated rural areas is 1 in 72. And our current rate is 1 in 44 nationally. So we're not diagnosing at the same rate in some of our rural areas, which is probably not a surprise for many of you to hear, knowing how much support or how little supports we're able to provide some of the communities in the more rural and frontier areas, right? Okay, next slide. All right, so this is kind of building upon what we know about screening and surveillance. So it gives us a few more numbers. So over time, we're seeing improving trends. More providers are screening across the board. So the reason why universal screening, as Dr. Ellzey mentioned, has the potential to reduce some of these disparities, meaning it can actually help us identify some of these kids who are not being identified, is because we're just going to screen everybody, right? It doesn't matter what your gender is. It doesn't matter your race, your ethnicity. Everyone's going to get an autism screen. So just by doing that, we up our rates, and that's working. It's showing that that's working, especially for Black children. The rates of diagnosis and surveillance are improving and are pretty equitable or pretty similar to their white peers. Not so true for Hispanic or Spanish-speaking families. The age of diagnosis and the rate of prevalence continues to lag behind. So overall, we see a better kind of age of diagnosis, meaning we're catching most of these kids earlier, but our Hispanic families still seem to be identified less frequently and as early. So below, I put some of the barriers that we know exist in terms of children just accessing screens or being screened and kind of experiencing that surveillance that Dr. Ellzey mentioned, which is so important. Some of them are pretty obvious, but some of them may be things we haven't quite thought about. So, for example, stigma, this means it can be a cultural stigma, it can be stigma on the provider's end or on the family's end. There may be kind of different perceptions of what autism is, right? And some families may not be ready for that diagnosis or that screen, right? Families who don't speak English are what we kind of refer to as English is not non-preferred language. Those families face a lot of barriers within the healthcare system in general, right? We know that is true across the board, not just in autism, but it also applies here. So it's something for us to be thinking about, right? How do you know which direction to go when you walk into the hospital if the sign is in English and you speak Portuguese? It creates a simple barrier that we may not all think about on a daily basis, but a real one. Lack of access, especially for our rural and frontier areas. There was a study showing that those children in more rural areas, not just in Utah, are diagnosed less frequently. So this happens across the board. And this is true for every medical condition, right? You see the trend here. All these barriers are barriers that are generally established within the healthcare system and not necessarily specific to autism. Some of the screeners that Dr. Ellzey mentioned are great screeners. We should use them, and we should use them for every child at 18 and 24 months. We should also know their limitations. They don't come in all of the languages out there, right? We also know that some of them function differently, specifically the SEQ, the social communication questionnaire that Dr. Ellzey mentioned for school age kids. We know that that one doesn't work as well for Black and Hispanic children. It works about 40% less well. That's pretty bad. So we need to understand the limitations of some of these questionnaires. So as you're choosing in your practice which screener to use, the idea is just to be mindful of how well that's going to apply to the child and the family that's right in front of you. So lastly, I'll just show you a diagram here, and you can go on to the next slide, of what a colleague of ours at CHOP put together as kind of this pathway of autism diagnosis and access to specific services. And then you can kind of see right in that referral and that referral to early intervention area, there's this dotted box. We often see kids fall through the cracks here. So everyone's doing a great job screening and surveilling pretty universally, but we know that not all the kids that need to be referred are being referred. And this is where we can do a little bit better in trying to figure out, why am I choosing not to refer someone? And as we go through our kind of next series of slides over the course of the 101, we're going to be talking more about what might be some of the reasons that kids fall through the cracks in this particular area. So I'll pass the mic back over to Dr. Ellzey, and she's going to give you, I think, some more tools and next steps.
Yeah, so really just to sort of sum up, as we've, I think mentioned multiple times and we'll continue to throughout the series, the whole purpose of this is to identify children early so that they can get interventions earlier. And so, if screening or surveillance reveals concern for autism, then it's really recommended that you do three things: refer to early intervention, a hearing evaluation, particularly for young children who have a speech or language delay, and then referring for diagnostic evaluation. And we can evaluate as early as 18 months. And so there is one of the things we should remember, Michelle, I'll remember it too, to put in maybe our email that we send out, is that the Department of Health does publish a list of autism evaluation providers. I should have linked to that, but certainly we love to see kids at our Center of the University Developmental Assessment clinics, but there are clinics throughout the state of Utah that do these evaluations, and so we can link you to that information as well. So with that, we have a little bit of time for questions, and we can go through some of the ones in the chat, or if anything else comes up, feel free to turn mics off and or mics on and ask questions, and we'll try to address those. So I think it's worth talking about, Ashley, thank you for answering Suzanne's question, but it's a very good one. This question of like, okay, well, if autism, if these kids are presenting later, then like, was it present at birth? Was it not present at birth? What is the nature of the developmental nature of autism? And what we think about autism is that it really is something, there really are changes in the brain that are present from birth, but that the sort of the clinical signs or the behaviors related to that can unfold over time developmentally. So just as, for example, a child who has a motor delay related to not walking, you might not notice that right away because you're not expecting a child to walk until 12 months. And so maybe you may notice things earlier on, and that's a little bit of a crude example, but that if a child has a significant motor delay, for example, they're unable to hold their head up, you would see that really early on. But if it's a more subtle motor delay, like let's say that they walk on time and then it gets to their 3 or 4 and they're having trouble balancing on one foot, well, that difference was present early on, but it may not be clinically obvious until later on. And so similarly with autism, there are, for children who present with more subtle symptoms or more subtle behavior signs, we think those brain changes have been present, but that they may not be clinically obvious until later on. Oh, Suzanne, you had mentioned like the possibility of prevention. It's a really interesting question. I mean, I think, and certainly I think Michelle or Ashley may have some more to weigh in on this, but typically, the way that we think about autism is that it is, a developmental difference, and that while the purpose of intervention is really to improve outcomes and functioning and ability, functioning and quality of life, and all these things in a person who's on the autism spectrum. But that like sort of making a autistic brain not autistic may not be the goal of intervention. I think that or may not even be possible. But I think the purpose of intervening early is to intervene at the point where it's clinically important or important to the child. So if a child is non-speaking at the age of 2 and is not engaging in reciprocal social interactions, those are things that you're going to notice and work on and want to help that child gain those skills. But if a child is doing those things and then it becomes more obvious when they're 5 or 6 and they're having trouble navigating more nuanced social interactions, well, that's the point at what you're going to want to intervene. And so I think for children who are diagnosed later, I don't know that the children we want to diagnose earlier are those children for whom those earlier interventions are going to be the most valuable, and those are for the kids with somewhat more obvious symptoms. And so there are children who have quote unquote milder or more subtle symptoms that may not require intervention until they're a little bit older and need to navigate more nuanced social environments. Those are really good questions and tricky ones. Other questions? I do encourage you all, maybe Amy, if you can put up the link again to our little Qualtrics survey, we would love to hear any suggestions you have for other topics or any questions you have or things you want to know, because we really do use that information in helping inform our planning for the year. So any input you have would be super, super valuable. And if there's no other questions, well, thank you guys so much for your attention and for your thoughtful questions. And please let us know if anyone has any other questions that come up. Feel free to reach out, and we hope to see many of you next month. We're going to be talking about diagnostic evaluation. So all those questions about what the diagnostic criteria are, we're going to dig into those next month, and it should be a really fun session. Billy, thank you very much. That's great.
Thanks, everyone. Have a good rest of your day. And watch for that CME email.